Welcome to Grand Rounds. Welcome to the Patricia and Julia Kingsbury Lecture. This is an annual event that we host to bring world-renowned breast cancer researchers to Yale in honor of Breast Cancer Awareness Month. I'm Dr. Miriam Lusberg, and I have the pleasure of introducing our guest speaker, Dr. Antonio Wolff. Dr. Wolff is a professor of oncology at Johns Hopkins Medicine. He's a co-director of the Breast and Gynecologic Cancer Program at the Sidney Kimmel Comprehensive Cancer Center. He serves as the COO of the Translational Breast Cancer Consortium and serves as the co-chair of the NCI Breast Cancer Committee. He's internationally recognized for his work in breast cancer biomarkers, particularly HER2. Those of you who are breast cancer practicing clinicians, we've all used his HER2 FISH guidelines quite frequently. As a practicing oncologist and clinical translational researcher, his research has been pivotal to improving the quality of breast cancer biomarker testing. And his research interests include new treatment strategies, the development and implementation of prognostic and predictive biomarkers, and also how to improve the survivorship experience of breast cancer patients and their caregivers. He's a Susan Komen Scholar, recipient of the Cancer Clinical Investigator Team Leadership Award from the U.S. National Cancer Institute, and has been recognized since 2017 as one of the world's most highly cited researchers in clinical medicine. He's more than happy to meet anybody who is willing to meet between the hour of 1 to 2 in the seminar room next to the Grand Rounds. So trainees or really anybody who would like to have additional conversation with Dr. Wolff, know that after completion of the lecture today, the seminar room is available from 1 to 2. So we have, I encourage you if you, no, we'll just present it, but so we wanted to really thank you for giving this Patricia and Julia Kingsbury Award. And I'll put this here for later, but thank you so much for joining us, and we look forward to your lecture.
Thank you. Thank you, Miriam. And thanks all of you for being here. I know there's a lot of people on Zoom as well, and it's always a treat. COVID was a strange time. We didn't have a chance to get together. It's a lot of fun actually to see people. Those of you, I think 1 o'clock from 1 to 2 next door, chatting about anything. I do remember as you were speaking, Miriam, when I was a fellow at Hopkins in the early to mid 90s, at that time, a young guy this tall, incredibly energetic, was already bald at that time with a backpack. I think we know who we're talking about. Larry Norton came as a visiting professor at Hopkins. This was 33 years ago or so, and that was incredibly impactful to me. And along the lines of being impactful, I do remember when I took my faculty job at Hopkins 27 years ago, is when I met for the first time another not so tall researcher who came to Baltimore for a meeting, and he was in the process of moving from Duke to Dana-Farber. And that's actually when I met Eric for the first time. Last night we had a lovely, lovely dinner. I'm incredibly grateful to everyone who took time off, busy week, family obligations. I guess Adriana with small children, for her was an excuse to leave the kids with the husband and have time with adults. And so maybe you should be thanking us that you came last night. But everybody's so busy. It's a lot of effort. The title for this presentation, I actually put it together, the title about a week ago or so, because I knew there was a need for CME stuff. And I joked that with a title like this, you can do anything you want. So This is a presentation that many of my colleagues could give as well. And so I hope I have a little bit of everything. There's a lot of material I'm going to try to cover and be fair with time. If I behave, we're going to have a time at the answer. As I was putting things together, I realized that actually New Haven is known as the Elm City. I guess everybody knows that. I did not know that. And this is actually the picture. This is my house. And that's right in front of the house is an elm tree. You can see the powering shadow over our house. One of the first things we did when we moved there was actually cable this tree as much as we could because we get a lot of wind. It could cause a lot of damage. But I think it reminds me, I was actually, Eric, from now on, when I look at this tree, I'm going to think of you. I've known Eric for a long time. He has been a mentor, a sponsor, a facilitator, a friend. And in some ways, I am the older brother. So I think, Eric, right now, you have become my older brother as well. And I have, Laios, Ian, and others, Marian. I think we're all part of this cohort of people that grew up together academically. So it's really neat to be here. These are my needs and objectives, which is essentially anything and everything about breast cancer. I joke that sometimes I feel like I'm a jack of all trades and a master of none. Research funding to Hopkins for a lot of the projects we do. I usually try to minimize conflicts of interest in terms of compensation and honorarium from industry. I like to be at the table, but minimize conflict. So this is obviously a gigantic pun. I mean, are we there yet? And it's actually fun for me to think about. I've been doing this for almost 30 years. Things are really a lot better. And I'll answer the question right away. Are we there yet? And the answer is, of course not. Of course not. There's a lot of suffering still happening. There's a lot of people dying from the disease, suffering from the disease, families, loved ones, and also a lot of people suffering from our good intentions. So in our road to try to minimize toxicities from treatment and increase the number of patients surviving breast cancer and living a full life and dying of old age, we need to make sure that they don't die or suffer from the consequences of our good intentions. Better understanding of biology. I joked that when I was doing my training, the only thing I needed to know at that time was how to give AC, how to give CMF, and how to use tamoxifen. That's it. That was breast cancer 30 years ago. And now it's becoming crazy. Every day of the week, we have a new press release of another anti-estrogen drug. And I'm having trouble keeping track of all of it. I'm sure a lot of you the same as well. Multidisciplinary care is huge. There's a component significant in many ways. I think of stage migration, and I have a word about that with AJCC 8 and what is it going to mean. But I think also we need to realize we are not, as I talk to patients are not walking cases or patients or walking breast cancer. These are people. And so, especially with COVID, we were reminded that health policy is economic policy, and economic policy cannot exist without health policy. That alone is a lecture on its own. These are actually, I was going back over a couple of old slides, and I came across this, which to me was really, it's sobering because we are privileged to be in where we are in the U.S. As you noted from my accent, I'm not from Baltimore, even though I have moved to Baltimore 3 times in my life. And I think realizing that, I mean, and even in the U.S. So in the world, breast and cervical cancer are major threats to health of women globally, especially in low and middle income countries. And it is hard to believe, but this is the reality. One of my classmates is actually in Madagascar doing cataract surgery in the Mercy U.S. ship. And talking about poverty, it's a mind-boggling what those countries have to face. But really, where you were born, totally luck influences what you're going to be, your care, what you're going to have access to, and perpetuate a cycle of poverty. These are the proportion of patients when diagnosed with metastatic disease. The US is one of the red ones on the left in the middle. And you can see, looks like the US is doing pretty well. And these types of graphs are more or less, swimming plots are more or less predictable. But this is actually pretty scary when you realize, so this is age standardized mortality in 2014, and you can see some pockets in the US, most of the US doing okay, the Southeast, Central Southeast, doing really not well. In the middle bar graph, you can see improvements in age standardized mortality, which is absolutely getting better. But when you look on the right side, blue means good direction over time, red looking into bad direction over time. And I don't need to tell you how, to a degree, unacceptable this is that we have in this country. On causes are multiple. Unfortunately, politics, political decisions make a huge difference, but it's unacceptable that we have what we have in a country so wealthy as we are. And then you have the epidemic of obesity and being overweight. About 40% of all cancers diagnosed in 2014 was essentially a cancer associated with overweight and obesity. And we are seeing that this is becoming an epidemic that is beginning to affect young people. We are seeing more cancers in younger people, often associated with diseases of inflammation. It is not acceptable. I don't know, I mean, and I'm preaching to the choir here because you guys all know this, so you're all nodding in agreement. I do not know how to fix this. A lot of this is actually going to rely on many of you, the next generation of investigators. I mean, a lot of it, again, are political decisions we all make. This has been one of the major developments in the last many years. We've known for a while breast cancer is an umbrella of phenotypes, and the phenotypes, they have clinical utility because they tell you you're going to do A or B binary decisions. It's a little bit like you're pregnant or not pregnant. You're not a little bit pregnant, so you need to make decisions on the basis of the biomarkers if they have clinical utility. David, Ram, and I, we've known each other for a long time, discussing this morning, when is a biomarker ready for clinical practice, if they are going to help you make decisions about treatment. I love this line because it is essentially, again, I finished my fellowship in 1995, and it's been 30 years. And it's fun to see that I have lived through the HER2 story. Many of you were at ASCO, I think it was 2 years ago, and there was the plenary session. Shanu Modi presented TDXD in tumors that were not HER2 positive. And that was a standing ovation, and everybody saying, this is the most impressive results I've ever seen. And for those, I would say, you were not at ASCO Orlando 2005, because that was a rock show, essentially. This is George Sledge as a discussant, and this is when Dennis Lehman and Edith Perez presented the first data from the trastuzumab trials in HER2-positive disease. The the metastatic trials, the phase 2 studies were in the mid-90s. I actually had a patient on that study. There are patients still alive from 30 years ago with metastatic disease. And it's really amazing to see when those data were presented showing what used to be a marker of poor prognosis. Now things are flipped around, and what used to be bad news becomes good news. The challenges, of course, with any Kaplan-Meier's in survival data, we begin to realize that we are treating way too many people. The question becomes, who needs therapy? Because we find ourselves treating 100% of the patients with HER2-positive disease. This is only 5-year data, so obviously things change. But the reality is, are the patients in between the two survival curves are the ones that we worried about. Those are the ones that we can change the nature of their disease. Many patients will never have a recurrence, and many patients, maybe they did not need treatment with a HER2 drug, or maybe did not need any therapy. Who are they? And that's when we talk about personalized, individualized therapy. That is the major challenge we have, how to enrich patients for the ones who need treatment and for the ones who don't need treatment. So we began to learn more and more after the adjuvant data came out. We're still learning how to deal with patients in metastatic disease. Questions we ask ourselves with CDK4/6 inhibitors. If you want, or ER positive disease, if you have progression on first-line therapy, do you continue the same strategy? Do you continue to target the same targets? We learned that in HER2 positive disease, the answer is yes. Continuing HER2 therapy after progression was meaningful. This is actually, we learned data on the adding now a second HER2 antibody. This is the pertuzumab data of taxane trastuzumab with or without pertuzumab for metastatic disease, the Cleopatra study. We learned about the role of antibody-drug conjugates in metastatic disease, the Amelia study, T-DM1 versus lapatinib and capecitabine, and then ION crop a year or two later with the Teresa study, T-DM1 versus chemotherapy in the second-line setting. It was a positive trial. Then you went into the first-line setting. Maybe T-DM1 should be used up front in the first-line setting with the Marianne study, and that was a negative trial. It was non-inferior, but it was not superior. So we are learning how to use an antibody drug conjugate. And then we have pertuzumab receiving accelerated approval in the pre-op setting. And all of us got excited that the pre-op setting is going to help us. If you have a pathologic complete response, that is a preamble to have a survival benefit for a specific drug across trials, complicated stories. But in any case, we now have the affinity trial, adjuvant trial, node positive and node negative disease, patients getting chemo, trastuzumab, plus minus pertuzumab, completely undifferentiated, everybody getting pertuzumab, and the results were really pathetic. I don't think maybe we could have anticipated that this is what the data would show. I don't think I was, but this was a giant wake-up call that we needed to change how we did trials. We could no longer afford to put every single patient in the same bucket. So can you figure out better ways to put patients in different buckets? The data, super disappointing when compared to the observed activity in the first-line metastatic setting survival, and also in the improvement in PCR in the preoperative setting, which led to the accelerated approval of pertuzumab in early-stage breast cancer. A reminder of quote-unquote stage migration, that the control arms of every time you launch a new trial, you use assumptions from old data, from old studies to say, this is what I expect the control group to do. And I'm going to show an improvement, reduction in the risk of recurrence, improvement in the hazard ratio. And the statistics get all messed up because the control arm patients continue to do better and better and better. This is not to say that we are finding the cure. It's just a reminder that we need to be very careful with assumptions and how we design the studies and trying to figure out who should be on a potential control arm. And this is the realization that things are complicated. So yes, ER positive, triple negative, HER2 positive, but subtypes within subtypes complicate things enormously. This could be multiple talks. I'm cheating a little bit because I'm focusing a little bit more in HER2. I'm also being lazy because that's the disease setting that I think I understand the most. ER positive disease, I think, is becoming complicated, mostly because we have way too many drugs right now. I don't know how many SERDs we need, how many PROTACs we need, how many. It's confusing. Reminds me a little bit of the battles of Taxol versus Taxotere in the 1990s. Reminds me of the battles of the various CDK4/6 inhibitors, which is the best one. I think we're going to be seeing a lot of silly noise, and as we begin to understand how to use ER drugs at this point. But I'm digressing for a moment. HER2 is complicated, but I think we are learning that not all HER2 tumors are the same. ER matters. We actually have data. This is a study that Eric helped put together. Lisa Carey ran the study when Eric was committee chair for Alliance with Cliff Hudis. So this is taxane trastuzumab with or without lapatinib. And you can see the likelihood of PCR, yes, more with the combination, especially if you have ER-negative disease, but you can see the more ER-negative disease, the higher likelihood of PCR. Here are data that we already knew. This is old data. All patients with ER-positive versus negative disease, ignore the HER2 data because these data were not collected then. But we know that the annual hazard of recurrence is higher early on in ER-negative disease, and it comes down dramatically after 5 years, to the point that for many patients, we are comfortable perhaps in saying, looks like you may be cured, although sometimes we see late recurrence in negative disease, but ER-positive disease, a more constant rate of recurrence over time. And now we have data this constancy remains after 10, 15, 20 years. I remember seeing patients when I started. I was seeing a lot of patients, women in their 60s, recurring with supraclavicular nodal low volume disease. I am not seeing that anymore. So in the 1990s and 2000s, I was seeing a lot of those patients. We now are doing extended adjuvant endocrine therapy. I am not seeing as many patients who had breast cancer in the 90s or 2000s recurring today. We still see them. What is interesting is that these patterns were observed in patients treated with HER2-positive disease. So this is the HERA trial, adjuvant trastuzumab, and after chemotherapy. So it was, for the most part, AC, ACT, plus minus trastuzumab. And this patterns of a greater recurrence in ER-negative disease early on and in ER-positive disease later on is recapitulated. And what is absolutely fascinating, mind-boggling, this is the patina data. Clinicians in the room, I enrolled patients on this clinical trial, which was run by the Alliance Foundation. This is a trial that it took forever to mature. And I think a lot of us were saying, we are not seeing any data. It has to be a negative trial. And telling you, you know nothing. The statisticians are smarter than we are, and they designed the studies. I mean, if there was futility, we would have seen the data. We just did not have enough events. And it was absolutely mind-boggling to see a week and a half before the data were presented by Otto Metzger at San Antonio that the data came out, and it was a positive trial, and it was hugely positive after accruing for so long. Lajos Pustai and I were just commiserating a little bit. I mean, Lajos is the study chair for SWOG 1418, which is pembrolizumab, as a single agent for patients who receive pre-op chemo for triple-negative disease and have residual disease. And we are waiting for those data. And we have at some point the data will come out. It's going to be chances are a time event versus, time driven versus event driven. We'll see, but it's been a long time. And who knows? I'm hopeful that it's going to be a positive trial. Maybe it will teach us a different way of potentially using these drugs. Immune pathways matter. And I'm just being very simplistic here to show that this is just using tumor-infiltrating lymphocytes. And the presence of TILs in the diagnostic core biopsy is associated with a greater likelihood of clinical benefit. We actually, Sunil Badvi from Emory is going to be, this is small, okay, no. We have data, let me put it this way. We do have data from Compass HER2 PCR, which is a neoadjuvant trial of THP and associated with PCR. We, in the near future, at a conference to be imagined, we are going to be presenting data on the effects of TILs in association with response as another potential marker to use. This is something we haven't done much until now. PIK3CA status in HER2-positive disease matter. We know this is data from Cleopatra, first-line TH plus minus P in metastatic disease. Patients who have PIK3CA mutations, it's a worse outcome for those patients who have HER2-positive PIK3CA mutation. It's a prognostic marker. Is it a predictive marker? Do we see a differential benefit from pertuzumab? The answer, at least from these data, is no. Do we have other data sets where PIK3CA may matter? This is actually, again, small subset analysis from Emilia. This is TDM1. and suggesting that maybe there is an possible interaction with TDM1, suggesting a differential benefit in patients who had mutation in PIK3CA. The point that I'm making here is that we've been so busy with so many drugs in HER2-positive disease that we have not explored targeting the PIK3CA pathway in HER2-positive disease. The studies have been limited in patients with ER-positive disease, but there may be something there. I wouldn't be surprised if we see some proposals, and actually one of my colleagues at Hopkins, Jesse Tao, he gave a presentation at TBCRC thinking about this. We have been very busy in the second 15 years. A lot of data that I just went through. We have data with neratinib, a drug that I do not know how to use. That's a separate conversation. Various approvals in the metastatic, in the adjuvant setting. We now have biosimilars. We now have subcutaneous formulations with hyaluronidase for both trastuzumab in the combination of trastuzumab and pertuzumab. And then 2019, late 2019, the most recent entries with tucatinib and TDXD. This is the last San Antonio meeting. This is from a presentation I gave right before COVID. So San Antonio 2019. Tucatinib, the HER2 CLIMB data. Another TKI, heme, GI toxicities, major CNS activity. That was a big deal. Nancy Lin had a nice presentation, publication on focusing on patients with brain mets. We had some noise with margetuximab. I'm not sure exactly the drug is available. I don't know yet how to use it. Ian and Eric heavily involved with TBCRC 052, Ada Wax presenting the data. And then the magic of another antibody drug conjugate, the DS8201 or TDXD, and Destiny Breast 01, suggesting then a drug that's clearly superior in many ways to other drugs in the HER2 positive setting. But then for the first time, we hear this term HER2 low, which kind of confuses me exactly what it means. We now have on TDXD versus TDM1, we have data on Destiny Breast 03 in the second line setting, showing a substantial improvement compared to TDM1. But this is a study that confuses me as well. These are studies that companies do when they are trying to get quote unquote clean data to lead to a label indication. And there's no question that it shows the potential value or shows the value of the drug, but it doesn't necessarily inform us how to best use the drug in the clinic, especially in studies where you don't have crossover. You don't have patients in the control arm being offered the investigational drug. And in this case, 3/4 of the patients on the TDM1 arm were never treated with TDXD. We just had another example with TDXD, sorry for the typo, TDXD and pertuzumab versus THP, Destiny Breast 09, that Sarah Tolani just presented at ASCO a couple of months ago. And there was no formal crossover to TDXD in the second line setting. So these trials become, yes, they do show how the drug would perform, but it becomes clinical trials of investigational, potentially superior drugs now versus investigational new drug never. And these, I understand why companies do studies this way, but they don't necessarily inform us on how to best use the drugs. And that actually made me go back 21 years. So this is an oral presentation that I gave a discussion at ASCO 2004. And I actually had to smile when I realized the title of my presentation, which was Optimizing Breast Cancer Therapy. So I was using the word optimizing way back when. My slides and the font colors are horrible, but that's how I gave talks at that moment. This is chemotherapy. And this is like the drugs are taxanes or docetaxel, gemcitabine, the G, the axis for capecitabine. And these are studies essentially at that time showing chemotherapy trials, the frequency of crossover. And if patients were not offered, a substantial percentage of patients receiving the new fancy investigational drug, there was a survival benefit favoring the investigational arm. When the crossover went above 25%, survival benefit tended to disappear. So that begins to teach us that it's not a matter of getting the new drug, is that if you get the drug at some point, you're likely to be helped. And that for those of us in the clinic, we make these decisions all the time. What is the optimal sequence of drugs? And that's where things are incredibly messy right now with HER2 positive disease. Again, thinking about when you see data, press releases, a lot of these clinical trials are clinical trials of new drug now versus new drug never. It doesn't take away from the importance of registering the drug, getting the data, but it doesn't really tell us how to best use the drugs. So, sorry. Moving on. So I think I already alluded to some of these issues related to any time that you're talking about a targeted agent and you're trying to identify who should be treated, a companion diagnostic test is needed, and that raises a lot of potential for confusion. You already get a sense of where I may be going with this when it comes to the HER2 story. This is actually what caught my attention back in 2005. This is a completely separate story, but I was in the pathology meeting, and I realized that the pathologists thought that we, all clinicians, were aware of the challenges with HER2 testing, and that's when I realized we were not talking to each other in the same room. That was the nature of the genesis of the collaboration between ASCO and the College of American Pathologists. This was the frequency of patients being enrolled in the adjuvant trials of trastuzumab, a substantial proportion of patients with false positive test results. And despite awareness and publications, almost 12 to 18% of patients with still false positive test results. You cannot practice medicine and take care of patients when you have tests that are so inaccurate. This is a long story of how we got into this business, but essentially the drugs were developed and we did not have a test. And at the end of the day, the realization that HER2 testing was not just a companion prognostic marker. It's not like doing CK, IH, cytokeratin IHC by pathology to find out whether this is a carcinoma or a hemalignancy cell. These assays are being the sole determinant of treatment selection. We needed to get it right. This is the genesis of the ASCO-CAP collaboration, and that's the funny part is that a lot of people think that I'm a pathologist, even though I am. Guess what? I'm not. I have opinions, but we actually, as I often joke, we are searching for the holy grail of diagnostic tests. We are concerned about overtreatment. We are concerned about giving a toxic and expensive placebo. So we want greater specificity. With fewer false positives, you don't want to tell an old man you are pregnant. That's clearly a false positive. The same, we are concerned about undertreatment, denying patients effective treatment. We need more sensitivity, fewer false negatives, the same as looking at a pregnant woman and saying, you're not pregnant. That's failing to detect a difference when there is a difference. That's a classic type 2 error. We went into the silliness on the retrospective data from the NSABP B31 study when Sunpeik published this letter into the New England Journal suggesting, guess what, patients with HER2 negative disease also benefit from trastuzumab. And long story that no patients with HER2 negative disease were enrolled in those studies, and they should have been, because they were not enrolled, we had to find ourselves 15 years later launching a whole study just for that patient population, B47. And at the end of the day, B47 was clearly negative. Trastuzumab does not help in the adjuvant setting patients with HER2 negative disease. But then we have a new drug, TDXD, which is a drug that actually does work in patients who don't have HER2 quote unquote positive disease, who don't have tumors that are HER2 overexpressed or amplified. And I think this is the favorite topic for David Ram. You have the expert in the room on the silliness of an assay that was never developed for the purpose that the companies are now using to try to use the assays in the low end of the spectrum. The assay does not have dynamic range to measure low levels of HER2. It was a test purely developed to discriminate amplification versus not, overexpression versus not, but not for the low end. But clearly, from the DAISY trial, we do see that we have patients on the right side that are so-called HER2 IHC0. They seem to be responding equally well. These cancers are HER2 not positive, but we just don't have the right test, and it may not matter. So we have this silliness. This is Destiny Breast 04, I guess, that led to the creation of a new category by the company. FDA goes along with the HER2 low determination. And there's no question that the drug, we have a drug that appears to be working not through traditional mechanisms of HER2 addiction, but is simply a better drug delivery, because we know, if you ask any pathologist, all tumors express some levels of HER2. The question is how much. And the guidelines, what to do about it, do we need to change? Is HER2 low a biological entity, or is this an artifact imposed by trial eligibility choices? The companies excluded IHC 1+ from Destiny Breast 04, and then in the subsequent trial, Destiny Breast 06, Ian was a discussant for the presentation at ASCO last year, excluded patients who had IHC 0 without staining. And I still don't understand whether it was a pure business decision, fear of negative data, that led the company to decide to create these untested terminologies, exclude patients from these clinical trials. But that's the reality of what we have. And 2 years ago, ASCO CAP issued an opinion on this. Clinical trial data on tumors that tested IHC0 were limited. Evidence is lacking that these tumors behave differently or don't respond similar to newer HER2 ADCs like TDXD. And the panel felt that it was premature to create new result categories of HER2 expression, such as HER2 low and ultra low. ASCO CAP does not recognize that. But we realized that best practices were needed to distinguish between IHC 0 and 1+ because of imposition of how the clinical trial was designed. Is this, at the end of the day, I mean, pathologists, they have to discriminate, they need it, between 0 and 1+. This is an issue of fixation, limits of the detection of the assay. Again, David has spoken to you, I'm sure, about all of this, and my fear is that this is an unfortunate exercise in futility to the poor pathologists as we try to make clinical decisions. I mean, try to differentiate the two slides in the middle and on the right side. One is IHC 0 with some staining. The other one is IHC 0 with no staining. It may mean nothing. And you can dial up and dial down the level of expression based on the analytical issues of the assay. And here are the data from the Destiny Breast 06. And they have as a unpowered, not even underpowered, completely not powered, small number of patients, 152 patients that were so-called ultra low. And those are the patients that ultimately led the FDA, which is a separate conversation, but they used those data to create and endorse the ultra-low definitions. And I think what everybody forgot to think about is that actually this has been in the ASCO CAP guidelines for almost 10 years, since 2018. And again, there are patients who were excluded. If they had no staining whatsoever, we absolutely have no data. These are data from David and colleagues looking at expert pathologists across 15 institutions, same cases, and trying to come up with what's proportion of patients classified along the IHC score from 0 to 3+. You see expert pathologists having a lot of variability. And I joke that we are trying to split the zeros to say that a tumor is IHC more than 0 and less than 1+. It is an oxymoron. And this is not insulting. This is meant, it's the definition of oxymoron is something that is contradictory. And are we going to have access to these tumors so that David and others can do more quantitative, truly quantitative assays? And what if the company had allowed patients with IHC 0 no staining to be enrolled in these trials? This is actually I like this slide because it's, if you're familiar with the term confirmatory bias, this is what this slide shows. This is actually my funny attempt of seeing what open evidence, clinicians know what open evidence is. So I asked the question, is HER2 low a clinical entity? And you can see the answer is the classification comes from a clinical trial eligibility. Studies have shown that HER2 low status is unstable, significant variability, and no consistent evidence that these cancers behave biological clinically different. That is the reason why you would create a category, because you identify patients who behave differently and should be treated differently. So obviously the answer is we don't have any data. And if artificial intelligence agrees with me, I'm obviously very happy. If it didn't, I wouldn't believe it. But this is obviously realizing, I love this slide. I'm trying to create an AI that can understand and use sarcasm. And how's it going? It's going great. The guy is a real genius. And the question is, was that sarcasm? I don't know. So anyway, talking about, I touched on these issues. We talked about the need to subset patients in different buckets so you don't treat every single patient. All of you here in this room are human beings, I hope, but you guys look all very different from each other. And I think it's the same situation in the clinic. Can we figure better ways to enrich for the trials we treat? So the neoadjuvant setting could be an accelerated path for drug approval. It hasn't worked quite well. We know that, at least this is an old slide, but so helpful for an individual patient, huge prognostic information. On a clinical trial basis, it's very difficult to use data from an individual, from a clinical trial, to truly know what's going to happen with that drug in terms of survival. Could you identify a subset of patients for therapy escalation? And we do have data. This is clear data from the Catherine trial. So now patients who receive neoadjuvant therapy and have residual disease, that information is super important. If I change the treatment, use a new drug, in this case, TDM1, on a specific subset of patients who has residual disease, I'm now enriching for a population that is likely to have a clinical benefit. That is a big deal. Could we identify subset of patients for therapy de-escalation? And this is now work that Eric was behind in developing, and this is the APT study. Eric and others had the vision to identify a scenario where a single-arm study in patients doing extremely well could, if showing excellent outcomes, lead to a change in clinical practice. The data presented by Sarah Tolani from Dana-Farber led to a change in clinical practice for patients with stage 1 disease, now using one chemotherapy drug, one HER2 drug. And this was also helped us put together the CompassHER2 PCR study, A1181, now focusing on patients with stage 2 and 3 disease. Nadine Tung is leading the study for ECOG Akron. This is the trial of patients getting one chemo and two HER2 antibodies, taxane and pertuzumab, trastuzumab for 4 cycles for patients who achieve a PCR and no more chemo. And if they have excellent clinical outcome at 3 years, this may become a new standard. The study was going so well that Eric and others made the recommendation, why not increase the sample size and allow us to better understand HER2 positive, ER positive versus HER2 positive, ER negative. This is the only neoadjuvant trial that is powered for survival. That is a big deal. And Nadine presented the data at ASCO showing the pathologic complete response. And once again, we see patients who are HER2 positive, ER negative, HER2 positive, ER positive. There's a difference in the pathologic complete response. We don't know yet whether all PCRs mean the same. Patients with ER positive disease have access to anti-HER2, to anti-ER therapy, so they may still do well. But this is the first study in the neoadjuvant setting that is powered to answer the questions of survival. We have a lot of data on these patients. We have blood samples. We can look at minimum residual disease. We can look at changes in ctDNA after 1 cycle of neoadjuvant therapy. We can look at patients with and without residual disease, positive or negative ctDNA. Does the quality of PCR matter? There's so many questions we are going to answer. This is simply to show that pathology matters. So tumors that have less ER, less PR, tumors that are HER2 by immunohistochemistry versus by FISH. And what was very interesting, patients who were treated with paclitaxel instead of docetaxel, a greater likelihood of PCR. And so this is where we are going. We are, for the most part, in patients with triple negative disease and patients with HER2 positive disease. The only patients going to surgery right now are patients with stage 1 disease. If they have stage 2 or higher, they go for neoadjuvant therapy. And we're beginning to see this perhaps with ER-positive disease. Lios and SWOG are running 2 separate trials on neoadjuvant therapy, one in triple-negative disease, but another one, SWOG S2206, patients with ER-positive disease who are MammaPrint ultra high. These patients are receiving neoadjuvant therapy. We may be in a scenario that only patients with stage 1 disease will go for surgery upfront. This is EA1211. We just completed accrual in ECOG Akron a couple of weeks ago, 200 patients. We are validating data from TBCRC 026 that's suggesting that a change in FDG PET from baseline to before cycle 2 could help us determine who's likely to get to a PCR or not. So the question becomes, can we use blood imaging and tissue at baseline to identify patients who may start neoadjuvant therapy with a little less, but if they don't have markers going the right direction, we may not need until surgery to make decisions about what to do next. So finally, I think I'm thinking about, as I said at the beginning, a lot of patients are doing a lot better, not everybody, but could we potentially think about doing less, and who are the patients we could do less? This is not a new concept. These are old data. On the left, we have data from NSABP-B13, chemotherapy or not in patients with small tumors. And the question, could we use tumor-infiltrating lymphocytes to identify patients with stage 1 disease who could avoid chemotherapy? That study is finally going to happen. The NCI Breast Cancer Steering Committee approved the TILS choice, which is going to be a study coordinated by Alliance and ECOG Akron that has a population of patients with stage 1 disease that will not receive chemotherapy if high TILS for triple negative disease. ER-positive disease, this is actually a couple of years in the middle, was one of the most fun papers I wrote with Marty Abeloff, who was Cancer Center Director at Hopkins, which was an editorial on trying to avoid chemotherapy in patients with ER-positive, node-negative disease. The gospel was by NSABP, everybody needs chemo. This is 3 years before Oncotype DX. And then the data from the APT study that Eric, Sarah Tolanian, Ian, and others did with T8 in the adjuvant setting. So what is the right language to use? De-escalation, reducing therapy, decreasing, de-adopting. You have to be careful because you're going to present this to patients, and patients don't like to have things taken away. We are in Nobel Prize week, and today was in physics, yesterday was in medicine. Richard Taylor had the 2017 Nobel Prize in economics talking about what's called loss aversion. So you don't want to de-escalate. You don't want to take away things. And that's when the word optimization, and I had a smile when I saw that I had used this in that ASCO talk in 2004. The point is, some patients need more, some patients need less, some patients want more, some patients want less. And we need to figure out how can we make better decisions in the clinic, recognizing that we have our own biases as well, and how we present stuff to patients matter. These are data from, actually from Yale, from a couple of years ago, a paper in the New England Journal by Donald Lanny and Sri Wang, talking about, it's a long paper, I encourage you to take a look, but he's asked an obvious question. Are small breast cancers good because they are small, or are they small because they are good? Kind of a convoluted chicken and egg thing to think about. But the reality is we really don't know. And the concern here is that we could be having the potential. What am I doing here? I apologize for that. The concern is that we could be having a situation where we could, even not just in DCIS, but in patients with stage 1 disease, that we could be overdiagnosing the patients, cancers, especially in older patients, possible in younger patients, but even more critical in older patients who may have stage 1 disease, but have a good chance of not evolving into stage 2 and a good chance of dying with breast cancer, the same way that a lot of men die with prostate cancer and not of prostate cancer or from prostate cancer. We are trying to do a little bit better. This is the AJCC 8 from a couple of years ago. We are now using more biologic information, not just anatomic information, biologic information, possibly using a lot of Oncotype DX. I'm not sure we need to order that much Oncotype DX, but you can see that by using some of these factors, tumors that anatomically would be higher stage are now called earlier stage. We did a fun exercise about 10 years ago. We did a model development and then internal and external validation. I mean, this is all of us in the clinic, we have our internal algorithm. You look at a pathology report, chances are you're going to guess, this is going to be Oncotype DX recurrence score high, this is going to be Oncotype DX recurrence score low, and the ones in the middle are the ones that I'm not sure what's going to be. I'm just going to order Oncotype DX for those cancers. When you do that, a lot of them come back in the middle, and that doesn't necessarily help us, but now we try to be more binary with a recurrence score of 25. I was mentioning to Lyles earlier today, I wasn't doing a lot of Oncotype DX at all about 5-7 years ago. Today, I'm doing a lot, in part because it's eligibility criteria for clinical trials. So I have a reason to be doing a lot more of it. And these are data that I think Adriana will recognize. I haven't seen the paper yet, Adriana, so I don't know where you are of that paper. So this is ASCO 2023, looking at the trends in breast cancer death and diagnosis. So the prevalence of stage 1 breast cancer has increased in the last 20 years. And despite excellent overall prognosis, I think we need to remember, just because of sheer numbers, there are so many more patients with stage 1 and 2 disease. Actually, those are the cancers. They account for over 60% of all breast cancer specific deaths. They are patients, or the patients that are concerning to us, obviously patients with metastatic disease, but purely on the basis of sheer numbers, more and more patients diagnosed with early stage disease. In absolute numbers, most patients who die are patients who started with stage 1 and 2 disease, and we have an obligation to figure out who they are. Can't wait to see the paper published. I'm putting pressure on you. So to everything, there is a season. Can we rebalance our thinking at time to de-escalate? Survival retains primacy, growing recognition of long-term effective therapies. Our patients have to live with our good intentions. A gradual move away from recommending therapies just in case. And I tell this to patients all the time. For a lot of patients with early stage disease, your risk of recurrence is not zero, but is very small. But for many therapies for early stage disease, the associated risk of serious side effects is small, but is not zero. We talk about the numbers needed to treat. We need to think about the numbers treated to harm as well. So in the next 2 hours, I'm joking, I did not touch at all on ER-positive disease, but this is from a couple of years ago, completely outdated. I mean, trying to create algorithms for ER-positive disease is crazy. But those are the challenges we are trying to deal with. Triple-negative disease, things are changing drastically. Yesterday, press release from AstraZeneca on the role of Dato-DXd in patients' first-line triple-negative disease without PD-L1 expression. So are we there yet? Of course not. That's a pun. But things are so much better than they used to be. And on that note, this is it. Thank you, guys. And I'm looking at the time. We may have 1 or 2 minutes for questions. So
Any questions or comments? Thank you so much for that great talk.
Slightly tangential, but you touched on it, so it's fair game. This idea that we're now, all novel therapies are all being, originally for the most part being tested in later line metastatic patients for registration, and now we're seeing all the move up trials going from third to second to first.
Yep.
And you pointed out that most of those trials don't have crossover, and most of them are done globally, so nobody's getting them crossover through commercial utility. So you can't really interpret PFS2. You can't really interpret overall survival in terms of where a drug should be. We have two trials getting reported at ESMO this year, I think, that are looking at two different ADCs in the first line setting. One has crossover, one doesn't. The one that has crossover so far has not reported a survival benefit. The one that doesn't have crossover, apparently, as of yesterday, did report a survival benefit. How are we as a community going to do this? Because the companies are motivated, and probably even more so after ESMO, not to allow for crossover.
So I could not have summarized any better, Ian. I think that this is, and I do not, let me put it this way, I don't criticize the company. I do, but I understand what I do. Eric is cheering me up here. But the companies, their primary responsibility, honestly, is to their shareholders. As much as they will say they have of course, they are in the science, it's a business. And they have to survive, and they have to make a profit, and they have to have dollars to do R&D. So they could have had, and they are not interested in diminishing their market. So the companies will do what the companies will do. I think we just need to recognize that that's how things are. This is potentially where your tax dollars at work could come in. There's a beautiful paper by Skip Burris in JCO talking about the value of the National Clinical Trial Network. I'm chair of the steering committee for breast cancer at NCI. Eric, I'm following the footsteps of Eric. He did that job a while back. You, Ian, have been a member of the steering committee. Those are the trials that the company will not do. And I think that those are the trials that we can and should do, the NCI could fund, because those are the trials of how do we practice medicine, when to use the drugs, quality of life, patient-reported outcomes. Those studies need to happen. But I want also to criticize the FDA, because the FDA could demand at the okay, you're going to do a pure study without crossover so you can get the signal. I accept your argument the drug is not available in outside. They do the study outside of the US, and then they come to the US where they have 70% of their profits and they get their first approval. I think the FDA could demand that companies need to confirm their approval. They need to fund the studies that allow crossover in the future. They're not going to like that. But why do they have, this is a free market. Why can they sell drugs at costs that are substantially higher, but then they are not obliged to help us better understand how to use the drugs? I think we have the power to do that. The FDA has the power to do it. Congress has the power to do it. I think it's a choice we make as a society. In the meantime, I think we have to rely on the NCI. Laios.
It's a great talk, Antonio. But the crossover is problematic because if you cross over and there is no overall survival benefit in a two-arm study, you can't tell whether the new drug actually improved survival or not. The only thing you can tell is that it doesn't matter whether you give it up front or you give it later. So you would need a three-arm study, which would dramatically inflate the cost and the price.
So I think I'm going back to the point that I made. I am not going to criticize I am criticizing the companies, but I accept the fact that they're going to do pure trials, not allowing crossover. So you answered the scientific question. But I think we need to have immediately after that a commitment by the companies that they will fund studies that help us figure out when to use the drugs. So that, because those are the things we need in the clinic. I need to figure out, what am I going to do? DB09, should I give TDXD upfront to all patients, or should I use TDM1 plus P? I don't know the answer to that. I can only infer from the data that are available.
Right. Thank you so much. We're out of time. That was a wonderful lecture. Thank you.
Thank you, guys.
It's great.